All right, good afternoon. Can everyone hear me? All right, so it is a little after 1 o'clock, and I will call the Green Mountain Care Board's meeting of December 5th, 2022 to order. We are here in Rutland, Vermont, the Leahy Center. Thank you all for coming in person. It's wonderful to see you all. My name is Owen Foster. I'm the new chair of the board. I've been here about 2 months, and I drove down from Jericho this morning, and I drove through my hometown of Middlebury and took a drive I often took when I was a kid from Middlebury to Rutland. When you're a kid in Middlebury, you spend half your time going to Rutland and half your time going to Burlington. And so it was really nice today to get a chance to make that drive and see the communities here. So we're here for the board meeting, and we'll start by having the board members introduce themselves so you know who we all are, and then I'll turn it over to our executive director, Susan Barrett, for the executive director's report. Tom, why don't we start with you?
Good afternoon, everyone. I'm Tom Walsh. I've been with the board almost a year now, started last January. I teach health systems and policy when I'm not with the board. And so over to you, Robin.
Hi, everyone. Robin Lunge. I've been on the board for just over 6 years now. I live in Berlin, Vermont, and I grew up in Brattleboro.
Hi, I'm Dave Merman. I've been with the board since October 1st. I'm an emergency physician, live up in Waterbury, and actually had a beautiful drive down as well.
I'm Jessica Holmes, and I've been with the board 8 years, and I live up in Middlebury. I also, when I'm not doing board work, I teach at Middlebury College. It's great to be here. It's great to be in person, and thank you all for hosting us.
Hi, I'm Susan Barrett. I'm the executive director of the board, and I've been here. My anniversary was just last month for 10 years, and I really love it.
I am Michael Barber. I'm the board's general counsel, and I've been here since 2016.
Great, thank you all. Before I came to the board, I was an assistant U.S. attorney at the U.S. Attorney's Office up in Burlington, Vermont. Did a lot of healthcare fraud work, also represented some FQHC doctors in medical malpractice cases, which I really found gratifying, and so I had a little firsthand experience working with some of our FQHCs. And with that, I'll turn it over to Ms. Barrett for our executive director's report.
Mr. Chair, I have to press the button. Can you all hear me? Great. So first of all, I want to thank the Rutland community for hosting us today. We're going to hear more about our morning activities in the community and hear more from presentations from providers throughout the healthcare community here in Rutland. And I do want to just have a shout out to a few people who helped my team plan this meeting, and that would be Tracy Moore. I saw her earlier from RRMC, Sherry Owens, there she is from the FQHC, and Kevin Robinson is here, and he is doing our tech, and this is the first time we've done a truly hybrid meeting, so I am very hopeful that Kevin will get us through this meeting. I'm sure he will. The other thing I want to announce is that we have several open public comment periods right now, and I'll also say that the board accepts public comment 365 days a year. We love to hear from the public. So please, if you get a chance, get on our website. You'll see active special public comment periods. You'll also see what we're working on. And if anything piques your interest and you want the board members to know about it, shoot us an email, go through that portal, or give us a call. But right now we have 3 open public comment periods that are special public comment periods, and that's one on the One Care Vermont 2023 budget. That is a review we're undertaking right now. We ask that you submit your comments before the board votes on that, which will be on December 21st. We're also looking at the state's Health Information Exchange Strategic Plan. That's a mouthful. That's a 5-year plan that the board is reviewing right now. And we'd ask if folks have comments to submit that. And then last but not least, we have an ongoing public comment period for a next potential all-payer model. We have an agreement with the federal government with an arm of CMS, which is called CMMI. It's the Innovation Center of CMS, and We may go forward with the next potential model, but we want to hear from all of you on your thoughts on that. Any comments we receive, we share with our partners at the Agency of Human Services and the Governor's Office as they are leading that negotiation. All of this information is on our website, and I'd just encourage you all to check that out. And we'd love to hear from you. And thank you again for having us today. With that, I'll turn it back to you, Mr. Chair.
Thank you very much. I'm going to take these a little out of order as we get through some of the immediate business, but I'll take the minutes from November 28th, 2022.
I'll move approval.
I'll second.
All those in favor, sorry, is there any board discussion? All those in favor, please say aye.
Aye.
Aye. And the vote is unanimous, and the minutes from November 28th, 2022 are approved. As we mentioned earlier, we did have site visits this morning here in the community, which was really important to see not just the hospital here, but also the Westridge Center, which is a treatment facility, and transitional housing center. And I think we all came away with some pretty significant reflections on the type of care that we have here in this community, that the community has provided for everybody. And so with that, I didn't get a chance, I was going to do this for the board, but I didn't get a chance to connect with each board member as to what their impressions were, what they took away. So I'll put them on the spot, and I know they're up for the task. First, why don't we hear from the folks that went to the emergency room department here at Rutland Regional Medical Center.
Well, the folks would be me from the board. We had some staff as well that came with us, but I want to thank the folks who toured us through the emergency room. It was really busy, as we've been hearing about the busyness of the emergency room, but I'd also say what struck me was it was a really well-oiled machine, clearly some really dedicated people caring for our sickest patients. It was nice to see the renovations that had happened since I hadn't been in the ED prior to the renovations, and the new suite that handles some of our the patients that are in psychiatric crisis. Really well designed from what we could see, the parts that we could see. Really well thought out how to provide care in a safe, caring environment for those patients. Some of the issues that came up that are probably not going to be surprising to anybody, and probably may resonate in some of the other areas that you all visited, staffing crisis, throughput. Heard a lot about throughput in terms of moving patients through the ED, out of the hospital into post-acute centers and some of that. But then the other topic that came up that I do think I would love to see us perhaps put on a future agenda item is workplace violence. And so the violence against healthcare workers and what we might be able to do about that. That seems to be an increasing issue in the ED, and obviously impacts morale, impacts health and safety of patients and providers and all of that. So those are some of the takeaways that I had. And a huge thank you to those who brought me through that tour.
And those are some issues we've heard across the state in emergency room departments, the safety of the employees working there and the volume of patients and where they can go. That's not isolated to the Rutland community. And with that, I'll turn to Member Walsh to discuss his experience at the FQHC, the Rutland Community Health and Express Care Center.
Yeah, thank you, Chair. We had a really nice visit. Got a tour of the facility and the pediatric facility next door. It was remarkable to hear how everyone adapted during COVID, from not just their protocols and operations, but really reconfiguring the physical plant. Right? And that adaptability was just remarkable. And hearing how the pandemic parts of it are, well, it's just different, right? I think it's a mistake to say that it's over, but it's different and shifting. And so trying to continue to adapt is stressful, right? And not knowing exactly what the future is going to be like, realizing that the way that it was before, it's not really going to return to that. So what do we need to be planning for, and how do we maintain our adaptability? I think all of those were themes that I took away from it. There were staffing concerns and need for more behavioral health specialists, more physicians. It was encouraging to hear that some of the best recruitment comes when students come here for training, then they want to stay. And people who are from here want to come home. And I think that speaks very highly of the community. How do we get more students to train here? And how do we get more young people to go into healthcare and come back? I think those are things to be thinking about. Susan was there as well, if anything else.
I would just add, I was really impressed with the coordination and the integration that the FQHC, Community Health, has with the hospital and other providers. We did hear the need for mental health, and it sounds like the FQHC, Community Health, is doing quite a bit of that and trying to keep folks out of the overloaded ED, so emergency department. I'm trying to not use abbreviations.
Just to build on that for a second, I think one thing that I'd like to think more about with our board and staff to see if there's anything we can do locally. FQHC's, some of the rules about mental health parity and billing are different for FQHCs than federal guidelines. I need to understand that better, to be honest. I was surprised to hear that. So I'd like to be educated and see if there's anything more we can do.
Thank you. And Dr. Merman, you went to the Housing for Health Bridge Housing Units, which is an innovative development here in Rutland that came together recently to fill a gap in care for people who need a home while they're seeking treatment.
Yeah, so my morning visit was quite a bit different, I think, than the others. It was not at a medical facility unless you actually, although Housing for Health makes a lot of sense, which was the campaign from the medical center here, I think, to try to raise money and awareness for the impact of homelessness on health. And it was just an amazing project that was done. The timeline that it took to get from grant funding to doors open was, what, 5 months? Am I getting August to December of 2020 in a pandemic, getting through Act 250 review, which is just amazing. Sailed through it in 2 weeks somehow. Must have had a lot of support. Just an amazing impact that housing can have on people's lives was really, really palpable by people's comments there. It is a really unique a unique project where so many different organizations, groups, grants, foundations got together with some pretty impressive leadership to get this thing through and provide housing for people in need. Multiple 2-bedroom apartments, a couple 1-bedroom, a studio, kids' place to play, help. And then all the services that go with it to try to to help people attain permanent housing. So it's a really impressive project. Your community should be really proud of what was achieved in such a short period of time. It's great.
Thank you. And Ms. Lunge, you're with me at the Westridge Center.
Yeah, Owen and I went to the Westridge Center this morning and had a tour and spent some time with their leadership, which was great. I would say a couple of my takeaways from that visit is that because COVID was such a disruption in sort of the basics of how they provided the care at the Westridge Center, they're still coming back from that. So transitioning folks who came in as new patients during COVID it was very difficult to have people in person in the number of patients that they typically see. Transitioning people back into that in-person model has been challenging, and they're not there yet. So I think that's just a theme that is likely to come up, and that for us as regulators to remember that for a lot of people in the communities, they're still making that transition back, and COVID is very much still top of mind. The other takeaway that I had related to some of the quality improvement work that they did. They have a quality improvement board, which I know many folks have, but it was just cool to see it and see what metrics they were focused on, and how that was coming back post-COVID as well. So those are a couple of my thoughts.
Thank you. I had a couple also in addition to those, and one big one was the coordination they have in treatment for folks that are struggling with addiction issues and how they coordinate that with inpatient, outpatient, and their treatment. They are not just a medication-oriented facility. They provide what they call biopsychosocial, and so you're really addressing all three elements that are needed to assist folks who are working through those issues. They also spoke about a coordination program they have for what was called guest dosing, which is if folks come up to Vermont and are on medication and need treatment, they can coordinate it through the Westridge Center to get their treatment while they're up here. Likewise, if those folks from this community are going elsewhere, they can coordinate guest dosing to maintain a healthy situation if they travel. The other thing that really stood out to me was I asked what percentage of the population that they serve are dealing with opioid issues, and they said every single person who goes through there. And they said that 99% of the tests that have opioids in it is fentanyl. 99% is fentanyl. And if you have any familiar with fentanyl, it's exceedingly powerful, dwarfs opioids, right? And if you get that mixture wrong, it is deadly and lethal. And so the fact that it's 99% of what they're seeing is really troubling, and we're fortunate to have the folks there helping people avoid engaging in that kind of risk. So we want to thank everyone who hosted us. It was a really enlightening day for all of us, and I think we learned a lot. I'm going to speak a little bit about the board. I don't know if I can see it. Just so folks have a sense of what we do and some of the issues we're addressing. This morning was great because a lot of what we hear are the problems that we're all facing and challenges. And so it was really neat to see a lot of the positives in a community coming together to improve healthcare, right? I mean, we're in a difficult situation with acute financial distress at a lot of healthcare facilities. We have staffing shortages, we have access problems, and it was nice in my 2 months on the job to hear a lot of really great positive stories. So anyway, that was fun. Just briefly, today we're going to have some presentations. You can see them here. I'll let the speakers introduce themselves and go through their presentations. The board was established in 2011, and we have 5 board members, an executive director, general counsel, and I think a staff of around 28 to 30. The board members are all appointed by the governor after a nominating committee process. So the nominating committee is non-political. There's folks from business communities, representatives, senators, and you go through that process first, and then your name may or may not be submitted to the governor for the governor to make a selection. And then there's confirmation after that. The terms are staggered, and they're 6 years. And so it's really a non-political board. The Green Mountain Care Board's vision is a sustainable and equitable healthcare system that promotes better health outcomes for Vermonters. And our core values is that we're independent, we're transparent, we're data-driven. We try to think holistically as to what our decisions have an impact downstream and upstream. We're collaborative, and we are accountable. And I think if I were to take any of those words that matter most to me, it's the transparency. Every board meeting we have is on this camera, and it's in perpetuity. So every mistake we make is there for you to see. And then we have public comment, and we welcome feedback, positive or negative, as to how we're working or what we should be considering in our decision-making process. You don't typically get that level of transparency in a lot of various government agencies, so I think that's a really neat part of the board. The other thing, the open meeting law prevents us from speaking with each other about issues that are before us. So when we go into a board meeting, we don't know. I don't know what Dr. Merman's thinking or what his view will be. And so we negotiate right there in the public along with you all. And I just think that is one of the more unique features of the Care Board. We're working to advance innovation in healthcare. That's some of the work we're doing with the all-payer model and trying to transform the way we pay healthcare so incentives are aligned. We have a lot of information and analysis available about all kinds of issues in our healthcare system that are available online for anyone to review. And we regulate major areas of the healthcare system here in Vermont. These are some of the features of our what we do on the innovation side. Beyond the things that we regulate, we also have advisory groups where we convene experts or folks working in particular fields to educate us and share information about challenges they face. One of the ones that meets very regularly and has been impactful is a primary care advisory group. We also have the prescription drug advisory group. We have a rural health task force. And as I mentioned before, we're working on the all-payer model work currently with AHS and CMS. On the information side, we have a data team that has 2 enormous repositories of health information. We have discharge information from our hospitals, and we have claims information of all the claims that are made for medical treatment. That information is used to conduct studies that give us insights into how our healthcare system is doing. One example was the wait time study that was performed. That tapped the data that's collected, analyzed, and based at the Care Board. On the regulation side, we regulate hospital budgets. We do insurance rate reviews. We review, modify, and approve plan designs for Vermont Health Connect and the Health Information Exchange Plan. We review major capital expenditures by hospitals through the Certificate of Need process. We have oversight and certification of accountable care organizations. And then we review ACO budgets. We also review the VITAL budget. On the horizon, this is an interesting time to be on the board because we're not just in the regulatory space. We have major big ticket items upcoming, such as the all-payer model. We also have the work under Act 167. And the financial health and sustainability of our hospitals is critical to the board. And we're seeing acute local and national rural hospital financial challenges. There's a national trend of really, really distressed rural hospitals across the country. And we're seeing financial challenges here. And ensuring the hospital financial stability is critical. It's really important that we have sound financial facilities here to serve Vermonters. Act 167 was passed last year, and it directs the Green Mountain Care Board to conduct a data-informed community engagement process. And the goal of that is to understand the state of the healthcare system that we have at community levels and support hospitals in ensuring financial stability and addressing any care gaps, making sure that the treatment that's needed in local communities is available and that there's financial stability. Just so folks know where we are, the Green Mountain Care Board published a request for proposal. We had taken a lot of input from numerous stakeholders across the state, and the bid review process. We've received a number of bids, and the bid review process is currently underway. Once a vendor is selected to assist with the community needs assessment, we will begin data and community engagement work to actually get on the ground in those communities. This is a graphic of the Care Board's scope. You can see here the little bubble is our primary role in regulating health insurance rates, certificate of needs, hospital budgets, and ACO oversight and certification. There's a number of important players in the healthcare space in Vermont that we do not regulate, but may be impacted by the decisions we make as board members on the entities we do regulate. So you have federally qualified healthcare centers where a lot of folks get their primary care. You have independent providers. You have ambulatory surgical centers, urgent care centers, out-of-state providers. Medicare and Medicaid are not within our bucket. Medicare Advantage plans, which are growing fairly rapidly here in Vermont, self-insured plans, and out-of-state plans. This slide could probably be a lot longer, but I wanted it to fit. So these are some of the challenges you all probably know better than us. We have affordability challenges where the costs of insurance for families, small businesses, medium-sized businesses are extremely, extremely high. We have access to care and significant wait times. We have primary care shortages. There are real challenges with mental health, substance abuse treatment, and long-term care. That's part of the issue we're seeing with why the emergency rooms are struggling, is because there's challenges with transitions of care and having people receiving care in the appropriate places. Like I mentioned before, there's acute financial challenges for our hospitals. Part of that stems from the workforce challenges. There are not enough nurses, there are not enough physicians, there are not enough of basically everything that we need in our hospital and our healthcare system here. Clinicians are really struggling with burnout. They are overloaded. They are asked to do too much. There's a significant administrative burden. There's significant burden alone from their electronic medical records that they're working with. We also need to improve telehealth, including trying to have audio only so that more people can access physicians when they need them. And then as we work through the all-payer model work, there are pros and cons of value-based payments. And so we're working through those, trying to craft with CMS a plan that will work for Vermonters. We took this out of order, so you already heard these reflections from our site visits. And with that, I want to turn it over to our presenters today. Then first is Jamie Bentley, who's the Community Impact Coordinator here at Rutland Regional Medical Center. And Ms. Bentley will provide a summary of the 2021 Community Health Needs Assessment and the 2022 Implementation Strategy Update.
Thank you. My name is Jamie Bentley. Oh, thank you. Perfect. Like Chairman said, I am the Community Impact Coordinator here at Rutland Regional Medical Center. My position requires me to provide the Community Health Needs Assessment for Rutland Regional Medical Center and be part of the Bowes Health Trust, which is a granting arm of the hospital. And the Bowes Health Trust uses the Community Health Needs Assessment as our guiding document on deciding what types of programs and projects we want to fund within our community to help improve the health of our community. So I just am going to run through quickly today about the Community Health Needs Assessment. This is a huge undertaking, as most places know who provide a Community Health Needs Assessment, and we started doing this work just before the pandemic hit. So we decided to provide a crosswalk of data in March of 2020 and really look at what's happening within our community, what is the data telling us as far as the needs of our community, and that crosswalk of data, that information told us that the priority areas we identified in 2018 were the same priority areas that still had significant need. So because of COVID-19 and the limited community capacity to really participate in a huge undertaking of a community health needs assessment, we decided to move forward with the same priority areas that we identified in 2018. We also knew that these priority areas were exacerbated by the pandemic. And I also want to point out that Rutland Regional Medical Center has been providing community health needs assessments since 1996. So this is something that we have been doing for quite some time. It wasn't required for us to provide this information for our community until 2010. So we have a history of providing this information and really focusing on prevention and understanding the needs of our community. The areas that we identified in 2018 and are continuing to focus our efforts on are listed above: supporting the aging community, housing as healthcare, mental health, including substance use, and childcare and parenting. We also realized that these 4 topics, while they have their own standalone issues and challenges, they all intersect with each other. We know that our aging community might have housing issues, they might have mental health issues, and same with our children and parents. If they are experiencing housing challenges, we know there may be some other areas that intersect with their health and well-being. So with the community health needs assessment and the implementation report follows up that initial assessment to say these are some of the areas in which we can provide strategies, programs, or projects that might address our priority areas. We found some overarching themes. And within the community health needs assessment, we really felt that health equity was a major aspect of this work. We really need to bake in and have health equity be at the foundation of the work and the projects and strategies that we are implementing to address the needs in our community. We also recognize that food insecurity was an issue across the board in all of the populations and groups that we identified as needing extra support. Of course, workforce capacity was also identified as an issue and continues to be an issue. And it's interesting still how that issue has changed over time. We're having different conversations now about workforce capacity than we were even in 2020. And then, of course, the impact of COVID-19, which we continue to see coming out today as different challenges and issues our community faces. Within the implementation report, we identified 4 foundational strategies that we think need to be thought about when we are providing strategies to address these priority areas. So health equity, again, we really focused on this idea that we need to meet people where they are. We need to focus on where people live, where they grow, where they play, where they work, to identify all the factors that impact their health and wellness. Data collection and sharing was another aspect. We know data is extremely important at informing our ideas, our projects. And so having a way to identify data and share data amongst ourselves so we have an idea of our community and its needs is really something important that we need to do. Having a multifaceted approach, if we're going to be successful at identifying and dealing with some of the challenges, we need to make sure that we're not just focused on one specific thing, that any strategies that we put into place, they hit multiple areas of our priorities. It's not just focused on mental health, but we know when we implement something that helps with mental health issues, we know it might also help our it might also help our aging community, or it might also help our children and parents. And then, of course, really identifying some of the major gaps in our workforce and how do we work on expanding our workforce, retaining our current workforce, and what's our community capacity. I think most of the faces I see in here of some folks that work in nonprofits would tell you that they are also at capacity. They're also working really hard. It's not just healthcare. Everybody is facing some of these challenges. So with that, I mentioned earlier the Bowes Health Trust. And the Bowes Health Trust comes in after the community health needs assessment and really focuses on what are the projects that we can provide funding to that will address these priority areas and will focus on some of those foundational aspects that have health equity at the foundation of their work and their projects, that look at food insecurity, that identify workforce capacity issues, that has great data and can share that data, and is addressing multiple aspects at once. So as you can see, it's through the Rutland Regional Medical Center. We provide grants every year, up to $100,000 to local nonprofits over a 3-year period to provide some of these projects and programs to our community. And really our mission is to fund collaborative, innovative projects that improve the health of our community. And as you can see, those are just 4 of the 8 current projects that we have going at the moment. Come Alive Outside, who you will hear from in a little bit, is one of our partners, is one of our grantees, and they're developing a mobile outdoor passport for underserved populations. We know that when people are connected to nature, they're connected to physical activity, that their physical health, mental health is improved. The Homeless Prevention Center, which Dr. Merman met this morning, was at the Bridge Housing and with Kevin Loso at the Housing Authority. have worked collaboratively to provide wraparound services to folks who are experiencing housing challenges to make sure that they end up in permanent housing. And then the Turning Point of Rutland County, they have really focused their efforts at making sure they can meet people where they are, because folks who are experiencing substance use disorder need people to come to them. It's not always about them going to a center or going somewhere to access help. They sometimes need those peer recovery coaches to meet them where they are. And then Rutland Mental Health Caregiver Support Program is identifying and working with folks who are providing care to their loved ones, because we know that folks who are caregivers often have poor health themselves because they're spending so much time giving to other people. So those are just 4 of our projects that we fund currently. We're in the process right now of identifying up to 3 more projects that we will fund in our community. And that sums up how the community health needs assessment really ties into some of the preventative work that the hospital and our community is providing here in Rutland. And from there, I will pass it off to Meredith.
Good afternoon. My name is Meredith Drood. I am the manager for the Community Health Improvement Department here at Rutland Regional Medical Center. I'm a licensed independent clinical social worker and have been working for Rutland Regional Medical Center since 2013 and in support of the Blueprint for Health. So the Blueprint for Health supports community-led strategies to improve health and wellness of Vermonters. Rutland Blueprint Patient-Centered Medical Homes and the Community Health Team, amongst other Blueprint initiatives, are at the core of care coordination efforts. I'd like to spend my time with you today to highlight the efforts of our Community Health Team and its successful partnerships within the community. So the Agency for Healthcare Research and Quality has a great definition describing what care coordination involves, which is a deliberate organization of patient care activities that shares information amongst participants concerned with a patient's care to achieve safer and more effective care. While that's an adequate definition, I don't think it gives the full justice to the complexity, breadth, depth that's involved in care coordination. I also think it limits and diminishes the active role that patients play in the care coordination activity. We can describe care coordination sort of at 2 different levels. One being broad care coordination, which is an example of patient-centered medical homes supported through the Blueprint, along with team care. What I'd like to spend my time with you today focused on is that specific care coordination that's completed by the Community Health Team. For our adult Community Health Team, we have an incredible team of a nurse case manager and social worker that truly provide patient-centered care coordination. They're out meeting with patients in their homes, in the communities, at their primary care provider office, or even in a community agency office like the Homeless Prevention Center, for example. Our goal is to create a shared care plan which identifies the patient's goals along with the barriers and stressors that they're experiencing, with a goal to diminish a duplication of services, but enhancing that collaboration by identifying who's on the patient's care team, while also looking at, are there additional care team members that would be beneficial to join? The other element of this is identifying what are the patient's healthcare goals and utilizing the skill set of our nurse case manager to provide some health education on managing those chronic conditions, as well as any additional information that they might have. Another key component to this work is that community resource connection and navigation of services. Our system of care, whether it's healthcare or the human services, is pretty complex. And our Community Health Team supports in that navigation and advocacy for those services. What our data is showing us is that there's an equal amount of direct care with the patient as well as indirect care coordination. So communicating amongst those care team members about the supports and services that are happening within our patients. We also enhance the collaboration needed between primary care and the community by creating a care coordinator designated for those patients without a primary care provider, and identified social determinant of health barriers that may be impacting their ability to access care. Initially, this position was developed to support specifically the Medicaid ACO expanded panel of patients. So those patients that are attributed into the ACO but don't have an identified primary care provider. However, when we were discussing this position, in terms of keeping equity and equal access to care in mind, we broadened this out because any patient without a primary care provider, regardless of whether they're attributed into the ACO or not, deserves to have access to this care. So we have an amazing care coordinator that is designated to work with the emergency department as well as other community collaborating agencies to support identifying those social determinant of health factors, whether that's transportation, housing or food insecurity, mental health, untreated substance use, interpersonal violence, to access those resources. What we are also finding is that there's an element of education that goes into this care coordination. Sometimes there needs to be a conversation about, why do I even need a primary care provider? What is the value of that? You'll hear in just a few moments about the Right Care, Right Place initiative, which we spend some time providing some information to our patients around when would it be helpful to go and see your primary care provider versus an urgent care setting versus the emergency department. What we are finding with this effort is that the majority of the work actually focuses on directly engaging with the patients first. So again, meeting with the patients in the community, in their homes, to build that trusting environment and relationship to allow for that future access to care and future care team development. The last lens, but certainly not least, is the incredible pediatric team. These two amazing social workers really are working with high-risk, high-complexity pediatric patients. So those are patients that, children that might be born with special health needs or have a special health needs diagnosis, along with social determinant of health factors such as interpersonal violence, housing insecurity, along with abuse and neglect. What adds to the care coordination complexity and needs of this population is you're not just working with the patient, in this case the child, you're working with their caregiver supports as well. It could be family, but it could also be a foster parent, a DCF guardian, and that enhances the increased need and complexity for that care coordination effort. One of the other challenges, and it's been mentioned a few times already, here in Rutland, we actually don't have a lot of access to specialty pediatric care. So we are asking our families and caregivers to go outside of our health service area. So we're traveling to UVM, Dartmouth, or even Boston Children's Medical Center to access this care. That further enhances the need to ensure that that communication occurs, but also there are transportation barriers, for instance, that may be impacting access to that pediatric specialty care. The other challenge that's been mentioned already too is just the limitation of the availability of supports, whether that's mental health or even childcare, after-school care availability. Right now, there are pretty significant wait lists for developmental assessments, along with access to children's integrated services such as PT, OT, speech. What we again see is there's an exponential amount of care coordination that goes outside of just the direct contact with those patients and families, but again, with that broadened care team communication. So one of the strategies that we have here in Rutland is to utilize the Blueprint for Health Accountable Community for Health model to support how we come together as a community to ensure that we are building healthy, thriving families. Our Accountable Community for Health occurs through the Rutland Community Executive Committee, the RCEC. which includes executive leadership from a number of healthcare and human service agencies, with the ultimate goal of building a thriving, healthy community. One of those examples or initiatives is through the Rutland Community Collaborative, which my colleague Andrea Wicker is going to share with you a bit more about. I just want to say again, this is incredible work that's being done, and again, think it's a great support for our community. So thank you for your time, and happy to answer questions after.
Good afternoon. How's everybody doing? It's a pretty nice day out, so I'll move over here closer so you can hear me, but thank you for having me. My name is Andrea Wicker. I'm the Director of Population Health and Quality at the Community Health Centers. I'm also a lot shorter than they are, so I'm going to do that. Can you hear me okay? Okay. And I've been fortunate enough to been working in Rutland for the past 10 years. I moved here from Pennsylvania, so I'm a Flatlander. And have been facilitator of the Rutland Community Collaborative for the past 5 years. So I'm here to talk to you about the amazing work that we have been doing and how we've been doing it together over these past few years, even before my time. So our mission of the Rutland Community Collaborative is we are committed to improve the overall health of the Rutland community through appropriate utilization and access of healthcare services. So I wanted to start with this today to express to you how we've taken, the leaders in the community have come together to develop this mission statement and feel very strongly that this is how we decide and agree upon what we focus on within the collaborative. So an overview and some evolution over the last few years are, we are a network of community leaders in healthcare. All the major providers in the community are in attendance, one being the hospital, primary care, our home health agencies, skilled nursing agencies, designated agencies, or our designated agency, support and services at home, i.e. SASH, Council on Aging, and community care. That's just some to give you an idea and to name a few, but there are many other organizations that attend our collaborative. So when did we start? We began in 2011 as the Congestive Heart Failure Collaborative, which was very population specific and was focused on bundled payments and improving healthcare through that lens. Over the years, we've had to go through evolutions and transitions, transitioning to the COPD Collaborative, then the All-Cause Readmission Collaborative, and to what we know it now today in 2018 as the Rutland Community Collaborative. That was a strategy to make sure that it was all-inclusive, that we could consider other alternatives to healthcare rather than having it being focused on patients who are getting readmitted to the hospital or only CHF patients or only COPD patients or patients with other diseases, but really taking the direction from all of the healthcare providers in the community to drive and decide how we focus our time, because our time is so precious. As you know, our workforce is very, very limited, but using that as a model for making sure that everyone's needs in the community are being met and prioritized appropriately. So one other piece I'd like to mention is that throughout COVID, the RCC was and still remains one of the main ways in which all of the healthcare providers in the community were able to share and talk about the issues that they were having, how they were getting through the pandemic, how they were working with masking policies, how they were working with vaccinations, how they were flowing patients through the emergency department for vaccinate. I mean, you name it, that is where the communication occurred. Prior to the pandemic, all of our meetings were in person, and we had to quickly transition to a virtual-based model, which now today we still remain all virtual. For the purposes of it's actually allowing more people to be involved and included in the conversation, where before it was a little bit more limited. And so now it's been able to allow us to have a shared space to communicate and talk about any issues that our organizations are having, and learn from each other and provide feedback to each other. So our structure, we have a core team, which is comprised of all of the key stakeholders in the community and maintains the overall direction. Essentially, it functions like a steering committee. And this is where those leaders get together and talk about and set the goals for the collaborative and talk through and bring up issues of where we should be focusing our efforts. And it provides, so then the second component of our structure are all the subcommittees. So there are many subcommittees that we have that are actually population-based focused. So we have a behavioral health committee, a clinical case review committee, education and engagement, palliative care and hospice, community-centered care committee, and a marketing committee. We realized a few years ago how we needed to have shared branding, a shared way of documenting and creating all of our campaigns, our education for patients, that would allow it to be shared through all of the organizations rather than one organization owning a piece of it. So feeling that having a marketing strategy would allow us to be more cohesive and more connected. And then the final part of the structure is our monthly stakeholder meeting. And this is where I referred to in the previous slide on how we were able to remain an active and engaged collaborative through the pandemic, was because we had this monthly meeting. It's the first Tuesday of the month. And it's a time where everybody has it set on their schedule, and we were able to use that as a way to share that information. So we have subcommittee members who only attend subcommittees and are working on specific projects. And then we have the stakeholder meeting, which is where we're able to have other members who just want to come and hear about the work that's being done. So some major accomplishments and initiatives that we've done over the past few years. One being we actually were able to get Dr. Mark Levine to come and present and provide a panel for our community, where we had many questions on masking policies, vaccination requirements, and things like that. And it was a great way for us to come together and have the collaborative be the conduit for that to occur. We do multidisciplinary case reviews where, based off of the conversations or the presentations that you heard, patients who are high utilizers of the emergency room are able to be reviewed or and have a time for us to come together and talk through what's working, what's not working, where can we improve systems of care, and how can we think about this not only from the patient perspective, but from a systems approach as well. Newsletters, again, making sure that everybody is informed and hearing about the work that's being done as much as possible. Training to improve community understanding around treatment for substance use disorders. One of our hopes is that we have a website that we can upload videos and trainings that can be available to everyone in the community who needs it. And one of those would be the substance use disorder training that we provided. Palliative Care and Hospice Committee has done an advanced care panel, directive panel, where it was virtual and allowed for patients during the pandemic to talk about advanced care planning, where they were concerned about what to do if they were to get sick and had COVID, and to have that planning done ahead of time was one of the really great events that we provided a community event that we provided in the last couple of years. And the other is a non-branded presentation on hospice care and palliative care and what it is and what it isn't. where our Bayada and our Rutland area visiting nursing come together and just talk about what the services are, not who's providing them. Tying back to the shared care plan from the blueprint, really promoting how do we use a shared care plan across the continuum and across our community to make sure that the patient's voice is heard. So this is one of our focuses over in the last few years. And more recently, the Right Care, Right Place infographic, which I'm going to show you in just a moment. Before that, we have a list of patient education journals where we're focusing on specific populations of need, one being heart failure, dementia, sepsis, substance use disorder, and COPD, and more currently, we're working on a diabetes. So the Rutland Community Collaborative, in essence, has evolved over time from just working on one population to multiple populations over time and trying to maintain and focus on that population as the needs change with the environment, social determinants of health, and the changing landscape of healthcare. So this is where a marketing committee comes in handy, providing education to the community on where to go and when. So a little backstory on this is this infographic initially started in 2019, the concept of creating a strategy in the community to direct people to the right care at the right place. COVID hit, we had to deal with that. And then flash forward to this year, we've resurfaced it and said we really need to put this out there. It really aligns with the RCC's mission. It aligns with what we're experiencing in our community in terms of the volume of emergency department utilization, express care utilization, and the lack of workforce to be able to meet the growing need. So this has gone through all the core team, the RRMC's PFAC, additional key stakeholders in the community, and the Community Collaborative, which has over 100 members to get final approval. This has been through the approval process, but the language and the way it looks and how to decide what to put on here was extremely challenging, but we all came together and as a team, as a community, to help make this happen and put it out there. So we have our primary care, urgent care, emergency department, and it's really simple, straightforward. Anyone can use this in the community. Whoever wants to use it, they can just take it and use it. So looking ahead, trying to tie back into how the RCC works with the blueprint and works with the community health needs assessment is that we're really taking direction from that community health needs assessment, looking at those needs and tying it into where we need to go in 2023 and beyond. So aligning our goals with the community health needs assessment is what we're planning to do in 2023. Focusing on health equity, one of those being a standardized social determinants of health screening tool across the continuum, mental health and substance use, the aging community. I'm not sure how many of you are aware of the statistics, but if you look in the community health needs assessment, Rutland is going to see around 130% increase in patients over the age of 65, I think it is. So we have that on our agenda. Housing, as you heard earlier, we have shortage on housing and ED and inpatient utilization. So where does that leave us? Well, I think we need to restructure, is what we're currently working on, to make sure that the committees align with the community needs and interests. Secondly, reviewing our membership again, making sure that we have all the right people at the table. With the workforce and the turnover that's occurred over the last few years, we've had to really keep an eye on make sure that we're pulling in people who need to be pulled in. As they transition here and move here from other areas, they're not aware, so we have to get that word back out there. Two areas being, we'd like to be more inclusive on the independent providers in the community and the patient-centered medical homes. And where I leave you is that I feel very fortunate to work in Rutland. I've been here 10 years and feel that the RCC is a great place for healthcare providers to come together and talk through how we want to see our community thrive over the next several years. So thank you.
Hello. My name's Arwen Turner, and I'm the Executive Director of Come Alive Outside, and today I'm joined by my colleagues, Haley Rice, our Program and Marketing Manager, and Myra Peffer, our Program Director. So spoiler, we are not a healthcare agency, but you probably know that. I like to think of us as healthcare adjacent. We are a nonprofit that works in partnership with the hospital and all of the healthcare agencies here in Rutland to get out into the community and help people find health and wellness in ways that meet them where they're at. So it's probably not a surprise to any of you that modern day lifestyles are not conducive for prioritizing mental and physical health. For the last 30 years, we've seen that lifestyle shifts such as sedentary behavior, being plugged into passive screen time all the time, and spending less time outside is having a myriad of negative health and well-being impacts. Amid the pandemic, we're seeing that children and adults are experiencing higher than average mental and physical health problems. And then even with a vaccine, we know that these years of isolation are going to have long-term effects. So super grim story, but not too grim, because here's Come Alive Outside, and that's what we're here for, is we're here to connect people to the health and wellness benefits of nature. And everything that we do is through collaboration. Oops. So we have 4 core programs that we are doing here in Rutland. The first one is our Nature RX program. And this is a program that we do most hand in hand with the providers here. Providers actually refer people to our program. They're given a nature prescription. And then for 12-week cohorts, we connect them with a one-to-one coach that meets them where they're at. For some people, this might be just spending a half an hour outside reading. For other people, this might be getting a hold of a long-term goal that they've had, like climbing a mountain or being able to snowshoe again or having more stability. It's all based on whatever that person's goals are and where they're at. Our next program that we have here in Rutland is our Mile a Day program. And this program is all about helping people develop a daily habit of mindful movement outdoors. This program has been our largest growing program in the last couple of years. In fact, we went from having 1,000 people in this program to over 11,000 people in just a couple of years. We recently were able to build an app for this program, and this program can be experienced by individuals or by teams. And each challenge that we have 3 challenges a year, we typically have around 20 different teams from work sites in Rutland, and those teams always include RRMC and community health. Our next program that we have is our Design Challenge, and this is our placemaking program, where we have elementary school students, high school students, college students, landscaping professionals, and community members come together to design natural spaces and then to put those spaces into action. And then our last core program that we have is our Outdoor Passport program. And this program is now for adults and for children. We bring it to every single elementary school in Rutland County, and this program is all about connecting people to hyper-local outdoor experiences where they work, live, and play. So you get a booklet that has 35 different activities. Those activities are connecting you to local green spaces, to different community activities, to the farmer's market, even things that you can do in your backyard. Those points for each activity, you get points. Those points equal prizes. So everything we're doing is fun ways to incentivize people to connect to nature. And this program, as Jamie Bentley mentioned, is also being turned into a mobile app. And our first rollout of that will be for priority populations in Q1 of next year. This graph here really shows the story of collaboration between the healthcare agencies in Rutland and Come Alive Outside. So since our beginning of Rutland, 5 years ago, we served 5,000 people, which is a pretty big number in a small community. This year, our reach has been 35,000 people. Now, when we're looking at this, we have to think about 35,000. Wow, that means that like 1 in 2 people are being served by our programs. it's important to note that this means that that's the number of times people are experiencing our program. So people come in to Come Alive Outside either through Mile a Day or NatureRx or because they've gone to one of our places or one of our community events, and we're finding that they actually engage in multiple different programs, which is better for long-term health outcomes. Another thing that you can see about this graph is that there's been a drastic growth in the end in that yellow part, the community events. And this is one of the things that we have seen have been so beneficial about our close partnership with our RMC and community health is we had to do some deep reflecting over the last couple of years about who is being served outdoors and who isn't. And those populations that are underserved in the outdoors are also the same populations that face the highest health inequities. So for Come Alive Outside, we needed to pivot and adjust the way of work. We can't just throw out a net and expect that everyone will have an equal experience. And so that growth right there, that is due to us being out in the community and really working with priority populations, not for them, to see what are the barriers to getting outdoors. How can we make it more welcoming? And one of the things that I think that we owe the greatest thanks to is working with Partners for Prevention, which is a grant-funded organization through our RMC. This last year, we have done such creative things to get people involved outdoors. We've brought Jedis to the park. We've had Potterpalooza. We've made scary trails. And although these things might sound like they're silly, entry through joy is actually a big, big key to social inclusion and feeling like something's for you. We all know that getting outdoors is for health and wellness, but we're not all motivated to do it that way. And so we're finding that having these community events is making a big difference in how people are engaging with our programs. And we wouldn't be able to do any of this if it wasn't for the partnerships we have with the healthcare agencies here. So I'm gonna hand it over to my colleague Myra to talk about REACH.
Now I have to figure out how this works. Which one do I push? Okay, thanks. What's so exciting for Come Alive Outside is that across all of our programs, the Kids and Adult Passport, Mile a Day, and NatureRx, we continually see similar successful results. In our surveys, we find that folks increase the physical activity, they have better mental health, and spend more time outside. So our programs are truly working. So I thought I'd share a quick testimonial from a single mom after the summer passport. And this is what she said: "The best passport story for our family this summer is that my children's enthusiasm pushed me to take them hiking again. I've had some health problems in getting older, just not able to do what I used to do. The kids missed it, and so did I, but just couldn't do it. We enlisted the support of a neighbor and took it very slowly with lots of breaks and found we were able to enjoy it together again. We've even made it to the top of Mount Scottney. I know that isn't in Rutland, but we hadn't hiked if we hadn't hiked the trails in Rutland and been successful, we would never made it and or tried Mount Scottney. So thank you so much. We had so much fun outside this summer following the passport activities." So that's one example. ParkRx began with the support of Rutland Regional Medical Center's Bowles Health Trust grant. And Sarah Narkowicz's UVM public health class evaluated the program in 2021 for us. Her students interviewed participants and compared it with the best practices in similar programs across the country. So it has now evolved to NatureRx with a more inclusive focus. With the support of community health, we are working to grow NatureRx in a way that reaches the people who could benefit from the program the most. So our long-term partnerships with Rutland Regional Medical Center and Community Health support the evolution of these programs to better support the people in the community. So I'm turning it over to Haley.
Hi, everybody. I'm Haley Rice. I am the Marketing and Program Manager for Come Alive Outside. And one of our core values is better together. And when we work together, we grow together. Come Alive Outside collaborates with a wide network of partners to expand our capacity and achieve meaningful impact and reach. And as you can see here, we work with about 40 local partners, and these people support us in kind or fiscally. But when you add in all of the schools and the libraries and the nonprofits who work with us, the number of partners skyrockets to over 100 people. or over 100 organizations, many, many more people than that. These are partners who provide input to our programs. They help us develop new ideas. They partner with us to do outreach, and they promote our programming to their stakeholders. So RRMC and Community Health are our two major partners, and they have made us a better, stronger organization through their ongoing support. They help us make sure that the work that we do is in line with the goals of the Health Needs Assessment. And they have also boosted our credibility to help us build new partnerships to expand the reach of our programs and secure sustainable funding. So I see some of our partners out there. I just want to say thank you so much. We literally could not do the work that we do without your support. So one of the favorite parts that I have of my job is that I get to hear all these great testimonials from people. So I created a video for you to show you some of the testimonials. So I'm gonna.
There were a lot of outdoor things I didn't think were for me, especially in the snow. But Come Alive Outside made me feel invited and welcome to try new things. I love snowshoeing now.
I've always been very active, and then I injured my back. I had surgery and used Come Alive Outside's Winter Wellness Passport to keep me motivated and moving while recovering. Now I'm back running marathons.
I was using my wheelchair most of the time to get around. And then I joined ParkRx a mile a day. And now I use hiking poles to help walk, and I even led a ParkRx hike for other people.
I had so much fun at Harry Potter. I loved making the one with my dad, and I also liked making that cool potion. It was very fun.
It seems like everywhere you look in our community, there's Come Alive Outside doing something fun outdoors. What I love about Come Alive Outside is that the programs meet people where they're at and celebrate all the different ways that people embrace wellness.
Thank you. And I will give it now to Susan. Oh, Chair Foster. Do you need this? No, I'm okay. All right. Yeah, you're welcome.
Thank you, everyone. That was really, I don't know, I was looking at the board members, they're all smiling during that last one. So I think there might be something to the nature RX.
Okay. My first. What can you say? My first guest is a biggie tonight, folks. Dean has not been with us.
All right, well, with that, we'll turn it over to any board questions or comments. I guess we can just go down the row if people have any questions or comments for the presenters.
I don't know who to address this to, but I was just curious to hear more about the shared care plans and when you started using the shared care plans and whether or how that's connected to the shared care plan information that One Care Vermont had been providing at least at one point.
Shared care plan. It's a great question. So that's an ongoing development, as you can imagine. It's definitely morphed. You can let me know, Andrew, if you have other thoughts and questions or comments. It's morphed over the years. So prior to having access to Care Navigator through One Care Vermont, Rutland Regional Medical Center actually utilized a shared care plan document through our own EHR to allow for the development of a shared care plan, which is actually what, for instance, the community health team is utilizing at this point in time. One of the challenges, as you all well know, is a shared care plan. The document to share it is sort of the challenge and the barrier that exists. One of the opportunities that we have is utilizing access to each each other's medical records, so collaborating with community health centers, for instance. The other key component to this is actually ensuring that the patient has access to the shared care plan as well. So ensuring the patient has involvement in identifying who is a part of their care team as well as those healthcare goals. So presently we're utilizing the shared care plan tool within the hospital's electronic medical record through the community health team, as well as community health centers care managers have a shared care plan as well. So it's continuing to go through its evolution stages, again, to allow for those additional care team members to have access to it.
Great. Go ahead. And I'll just comment on community health's work on shared care planning. One of the current focuses is just making sure that a patient knows that they have one. And one of the things that we've discovered over the years, just looking back at what's been done, is that in the medical world, from a medical model, the patient is informed of what care they're providing versus hearing from them what care they would like, going back to Meredith's point. And so at Community Health anyway, we're starting with just making sure that every single patient who has a shared care plan is provided a copy, and also informed on and asking them who they would like their shared care plan shared with, and then giving them enough copies to be able to provide that out. So that's sort of a placeholder for what we would really like, which would just be able to send it to their EMR virtually.
Thank you.
I had a question for Ms. Rice. Where are you guys operating, and how does the community find you and these opportunities that come alive outside?
Does this work? Oh my God, it does. So we're based in Rutland, downtown Rutland. We have a great view of the Walmart. And so one of the things that we do is we have funding to get our passports for children into the public schools. So we're automatically in the public schools with our summer and our winter passport. We also have a very nice social media presence on Facebook and Instagram. And let's see, how do other people find us? Word of mouth. The Mile a Day program you can find actually on the App Store, the Apple and the Google Play Store. And I don't know, Arwen, is there another? Oh, workplaces. Yes, of course, workplaces. We work so well with, what is the? VHI. Thank you. So VHI has found us and has been a huge supporter. And so a lot of the teams for our Mile a Day challenges are schools. And people get together and they have like a cute name and they walk at lunch. It's wonderful. And then, I don't know, is there anything else you'd like to add? Oh, community events. Oh, yes, community events. See, when I talk about collaboration, this is what I mean. Everybody's like, oh, you do that, and you do that, and you do that. So yeah, as Arwen mentioned before, people will come to something like Potterpalooza, and then they'll join Mile a Day, or then they'll do the Kids Passport. And so since COVID restrictions have lifted for the most part, we've been able to be out in the community and sort of get people in for these really fun events, and then they come and they do something else with us.
Great, thank you.
Thank you.
Well, first of all, thank you. It's been an incredibly inspiring day, and I really appreciated seeing all the collaboration across so many different community providers, the innovative programming, all of that. It's really, truly inspiring. So I'm curious about the health equity. It's such an important goal, and also appreciate the emphasis in this community on trying to, improve health equity. And I'm wondering how you'll measure success. I know you're laughing, and it is a hard challenge. So I'm wondering, what does the next community needs assessment look like that you'll say, yes, we've moved the needle on health equity?
That's a great question. And the short answer to that is we don't know yet. The immediate answer is we're working really closely. Bowes Health Trust has really made an intentional change to make health equity a foundational aspect of any program that we fund. So
we're working really hard with our current grantees and potential grantees to make sure that that piece is foundational and baked into any programming that they're doing. On top of that, there's other initiatives that are happening in Rutland County. We have the JEDI Collaborative. The Castleton University has started the Center for Social Justice and Trauma-Informed Care. So there's other avenues where we are hopeful that working together we'll be able to start collecting data that's reliable and usable to see how we are making improvements, because we realize that's
so important, but it's so hard to
Yes,
measure, right?
exactly.
I mean, I know I was asking you a hard question, and so, pardon that, but I think we can still learn from what you're doing, right? And other communities can learn from the efforts that you're making to try and make it a goal, a measurable goal, and track progress on it. And so I very much appreciate that effort that you're doing there. And
Thank
I think,
you.
as you learn how to measure it, we'd love to hear more. Because
I'll keep
hard.
you informed.
Yeah.
And also, again, we're not doing this on our own.
Right.
That if there's one thing to take away is that the collaboration that happens within Rutland is really pretty amazing. And knowing that there's multiple initiatives happening throughout our county and our area, but that we are able to all work together for that greater good has been really wonderful.
And I think, it was really nice to see the social determinants of health assessments that are going to be done across the whole care continuum. That's one way to measure progress, and I think that's an important initiative that I'm seeing here that I really appreciate. So thank you for that.
Thank you.
I just want to add a comment about the social determinants of health screening. So this has been something that's brought up for many years, and one being deciding on, as a community, what screening tool to use. That being the most challenging, the most complicated part of the decision making, because if we're all using different screenings, that's all different data, and that makes it more challenging to determine what's actually the need. So to start off, we're going to choose one question from one standardized tool and try to apply that across all of the organizations that have a touch point, just to start somewhere, simplify. But it'll likely be related to food, housing, or a financial related social determinants of health question.
Thank you.
And with that, I'll turn to the healthcare advocate.
Thanks, everyone. Mike Fisher, healthcare advocate. I think my question maybe applies to a number of the initiatives we heard, but I'll focus it on the Come Alive Outside. Whenever I hear a presentation like this, I wonder how much you're on your own here in Rutland doing this, or how much, and I know there are initiatives like this in other communities, but I wonder how much there is cross-pollination, best practices, whether you're learning from each other across the state, or whether you're making it up here.
That is a really complicated question, but I appreciate it. So because Come Alive Outside does everything in collaboration, by that in its core, we are constantly working with other people to make sure that we're not going into a space and taking over, that we're looking at best practices and we're looking at gaps. We also try to keep up to date on other initiatives. We partnered for the last couple of years with Rise Vermont. We are happy to share our resources with other communities, and that's one of the things that we actually do. We've duplicated our programs here that we've done in Rutland and 5 other communities in Vermont, in Massachusetts, in Ontario, and in West Virginia. So I know that we can always be looking at what's similar and different, but there is a unique thing here in Rutland about how much the community supports us and how we're able to work together. And we haven't been able to thrive here, but we are working on what is that recipe so that we can duplicate this program in other communities with similar resources and needs.
Thank you, Chair. I've been sitting here kind of debating whether to to ask a question or make a comment, because the thing going through my mind is a story, and it's a little bit of an emotional story, so I hesitate to tell it. But I want to preface that by saying what a great job it sounds like you all are doing. And I base that on experience. And the story that comes to mind, I was working with an organization with Navy Medicine in Jacksonville, Florida, and we were trying to help healthcare providers better identify patients with needs. So patients who perhaps had diabetes that was hard to control, their A1C level was quite high, and maybe they didn't come in as often as they were supposed to. And so we instituted a new protocol. We had the providers, somebody on the team, ask every patient, how overwhelmed are you by all you have to do to take care of your diabetes? 0 to 10. And the protocol was anybody that answered 2 or more, you followed up and said, what has you overwhelmed? Right? And that really helps focus the treatment session, right? And you make a new treatment plan, and then the next protocol was to say, how confident are you that you can do this protocol? 0's not confident, 10's fully confident. And then we flipped it, right? If they said anything over less than an 8, it's like, your 4 is okay confidence-wise, but what do you need to get to an 8? And I've come to believe that's the most important question that healthcare providers can ask, right? Including myself when I'm taking care of patients. But what this person said at the time, she said, well, my confidence is a 2. I said, well, what do you need to get to an 8? And she's like, I don't think you can help me here at the doctor's office. I said, well, what do you need? And she said, well, you want me to eat better and exercise, but my husband drinks a lot. And so when he gets home from work, I just try to feed him anything I can. Right? Try to feed, whether it's fried chicken from a box or pizza from a box or McDonald's or whatever. Because, sometimes when he drinks a lot, he hits me. But if I feed him a lot, he won't get drunk until the kids are in bed. And when providers started hearing stories like that, they're like, Tom, why did you teach us to ask these questions? What the hell am I supposed to do? Right? But what patients then need are the things that you guys are doing, right? Housing insecurity, physical security, learning how to access Al-Anon meetings, all of the types of things that you're talking about. And the question that Chair Foster brought up, how do you get found, right, comes from teaching providers how to ask those questions. Right? So it's a really, I'm thrilled to be here and hear about what you're doing, and hope that you get what you need to get into the offices where providers have the opportunity to say, you need the Nature RX, or you need the community resource, and here's the person to contact. Because leaving it up to that woman to find you, she's not gonna. Right? So just thanks for sharing your stories with us. They're terrific, and it's great to see.
Thank you for sharing that, Tom. With that, I'll turn it over to any public comment. And I've never done a hybrid one, so we'll start in the room, and then we'll go to any hands raised.
Hi, thanks. Thanks. I'm Lewis Myers, one of the hospital physicians here. Question I have is not directly related to Rutland, although I think it may be in the near future. This morning in BT Digger, there was an incisive commentary by Bill Schubert about private equity companies who nationally are beginning to buy up all of the, go into communities, buy up the nursing homes and other healthcare facilities. They quickly try and squeeze every ounce of profit they can out of it, and in the process decrease the quality of care and increase mortality. I suspect that a private equity company would not be so much interested in the wonderful services we're hearing today. So my question for the board is, as we look forward, I don't know how many of these private equity companies are in Vermont right now, but I think they will be. How are we going to deal with an onslaught of private equity companies buying up our nursing facilities and our other healthcare facilities?
I think it's a great point. I haven't read Mr. Schubart's article yet, but I read most everything in the Digger on that topic. I don't have an answer for you today. We don't regulate private equity companies here at the board, and it depends on whether or not they buy anything that we regulate as to whether or not our authorities will reach them. Nursing homes are not within our purview, so I think the short answer as of today is that it's not within the board's authority, but perhaps that changes in the future, and it depends on what they buy. Whether or not there's some other solution to private equity regulation in the healthcare space, I think it's an important thing to look at myself. But thank you for pointing that out.
My name is Mary Lou Bolt, and I haven't been involved with the community health team here in Rutland for 6 or 7 years now. So to hear what was going on today is pretty amazing. And about 3 months ago, I went into the Blueprint and looked at the data there. And they didn't toot their horn, but they're the best in the state. All the data supports that they're doing the best of anybody in the state. So I just thought you ought to know that.
We should know that, and thank you. Okay, and with that, I'll turn it over to any public comment from folks that are on the video, and use the raise your hand function, please. Okay, seeing none, is there any old business to come before the board?
Thank you, Mike Fisher again. Just the other half of the sentence I started earlier, really cool stuff. We're hearing really cool stuff here. And I know that there's really cool stuff happening in communities all over the state. You go to a community and you ask people to come forward and they'll tell you the good stuff they're doing, and we'll hear about good outcomes. I'm afraid that we don't learn from each other. I'm afraid that we don't have mechanisms to cross-pollinate those good ideas. And you can dream up ideas of how to sort of create the structures to do that, but I think it's a need.
Hi, I'm Ann Donahue. I wear multiple hats for today's purpose. I am with the mental health advocacy community from Vermont Psychiatric Survivors. And I think most people know that the community needs assessment here and across the state for, we can say now, decades, because it's been required since 2004 to do them, that mental health is always at or near the top. And to piggyback a little bit on the healthcare advocate, over time we have had some state level priorities on related issues, both when we discussed health equity. There's now a health equity commission. There's also an integration council for integrating mental health into the healthcare system fully, which again might be some of those tools for connecting different pieces in the state and learning from one another. But one of the things that it felt to me in hearing, even though that's identified and recognized as a need impacting the emergency departments and so forth, I didn't hear a lot of initiatives addressing that need, and heard a lot of actually specific gaps. And I think the one that kind of most really hit me right in the face in a very big way in terms of thinking about our goal of an integrated, holistic whole healthcare system where mental health is a full component of a healthcare system, not a system of its own, was the infographic, which said, here's primary care, here's where you go to urgent care, here's where you go to the emergency room. Mental health was not on it. Thank you.
Okay, and there's a hand raised on the video. Ham Davis, please go ahead.
Thank you, Mr. Chairman. I know there's a lot of, one of my questions is that the cost and quality of the system is always at issue here. I remember that the last time that about 6 or 7 years ago, your board, different boards obviously, but some of the same members, went to Rutland and went to Castleton to do the Rutland budget. And one of the comments that was made there was that, well, the Judy Fox and budget was sailing right through and everybody loved it. Comment was raised that just asked about, did anybody realize that Rutland had the highest per capita cost in the state? And there was no answer to that. And so I would just ask this question. Since for over a year now, you've had data coming in from all directions in your records, okay, about what the system looks like. And this is just a number you might think about, okay? The cost per capita in 2018, cost per capita from Rutland for a Medicare patient is $9,600, okay? The cost per capita in Burlington, which is where you've cut the budget for 6 out of 7 times, is $65.23.66. And these data are age, sex, race, and price adjusted. So what it looks to me like is that not a single question comes out of this board, okay, about either the quality of the care that is measured by PQI or avoidable care by Mathematica. I don't hear anything, any even slight discussion of this. Doesn't even get acknowledged. I think that's interesting. That wasn't a question. Sorry about that.
No, thank you very much, though, for your comment. And Mr. Robert Hoffman, I see your hand is raised. Please go ahead.
Just in response to Ham, as typical, he's not very good at reading pro formas. If you get into the population payments of the UVMMC budget, you actually look at what those all-inclusive payments are per capita. They're 200% and 300% of the Medicare and Medicaid payments enjoyed by the rest of the state. And they're covering hundreds of thousands of lives at this point. So I just encourage him to do a little more diligence and get into the weeds.
Great. Thank you very much. Real quick, I want to say a couple of thank yous, and I appreciate you guys sitting here for my thank yous. But this was a lot of effort by a lot of people to put together this hybrid setup. Christine Lajeunesse, Christina McLaughlin, Julia Bowles from our office, thank you all very much. Kevin Robinson, Tracy Moore, I know this took a lot of effort, and we just get to show up, and it runs seamlessly. So thank you all very, very much for that. Chair Mullen is here. Former Chair Mullen is here as well. I'd like to thank him for his years of service on the Care Board. Having been the chair for 2 months, I can appreciate how challenging his many years of dedicated service were. And before we started, I asked him if he wanted his seat back, and he politely declined. But Kevin, thank you very much for all you did for the board and for Vermont and all your work, and I hope you're enjoying your retirement. Great. We have a couple of legislators here as well, and I'd like to thank them for their attendance and paying attention to all that's going on. And lastly, Claudio Fort, thanks for your leadership here at Rutland Regional, and good well wishes to you in your next steps. And Judy Fox, thanks for stepping up in the interim basis, and I know it's a hard role. So thank you. And with that, is there any old business to come before the board? Any new business? And with that, is there a motion to adjourn?
So moved. Second.
All those in favor, please say aye.
Aye.
Aye. And thank you all for having us, and have a great day.